right. Thank you so much, everyone, for joining us today. We're going to have a wonderful panel discussion. I have with me some wonderful women from across the globe, and we will be discussing on an important topic with the hashtag that has been trending this month for International Women's Day and month in general, which is hashtag break the bias against women in global surgery. I will start by introducing my speakers. So we have Dr. Beverly Chesserem with us. She is a consultant neurosurgeon and assistant professor at Aga Khan University Hospital in Nairobi, Kenya. Her subspecialty interests rest in skull-based surgery and pituitary, both microsurgical and endoscopic techniques. Her other interests include global health, teaching, and clinical research. She has been a skull-based fellow at University of Wales and consultant neurosurgeon at Brighton and Sussex University Hospital, UK. She obtained Bachelor's of Medicine degree with honors from the University of Southampton, UK, completed her residency in neurosurgery in South London Neurosurgery Rotation, and currently she's the chair of the Kenya Association of Women Surgeons. Thank you so much, Dr. Chesserem, for joining us today.
Thank you.
Then next we have Dr. Julian Sosa. Dr. Julian Sosa MD, MA, FACS is a professor and chair of the UCSF Department of Surgery and holds the Leon Goldman MD Distinguished Professorship in Surgery. She received her AB at Princeton, MA at Oxford, and MD at Johns Hopkins, where she also completed the Halstead residency program and fellowship. Her clinical interest is in endocrine surgery with a focus in thyroid cancer. She is widely published in outcome analysis, as well as cost-effective analysis, meta-analysis, surgery-based research. Dr. Sosa is the newly elected editor-in-chief of the World Journal of Surgery, having served previously as deputy editor of the JAMA Surgery and associate editor at Journal of Research. She has been on editorial boards of Annals of Surgery in Surgery, Annals of Surgical Oncology, Endocrine, Hormones and Cancer, Journal of Thyroid Research, and International Journal of Endocrine Oncology. We are so pleased to have you with us in today's panel, Dr. Sosa.
Huge privilege. Thank you so much.
Thank you. Then we have Dr. Mamta Swarup, who MD, FACS, IFICS, and FAIM, Director of the Sadhana Trauma and Surgical Initiative, USA. Dr. Swarup is a dynamic, collaborative, and visionary academic, global trauma surgery leader. She has been a national and international visiting professor and keynote speaker. She has authored over 65 peer-reviewed research articles and book chapters, chaired numerous symposiums, and mentored over 100 rising leaders globally. For the past 11 years, she has excelled as a trauma, acute care, and critical care surgeon, researcher, and mentor at Northwestern University. Her lab, the Sadhana Trauma and Surgical Initiative, the Sadhana Foundation, aims to build sustainable access in healthcare in low-resource settings by conducting community-directed research and programmatic development in Southeast Asia and Americas. Thank you. It's such an honor to have you with us, Dr. Swarup.
Thank you so much for having me. It's my honor.
Then we have Dr. Purva Patel, who is a medical doctor and MSc public health student studying at the University of London. She currently serves as the Vice President for Internal Affairs for Incision and was the Regional Liaison for Southeast Asia for Gender Equity Initiative in global surgery last year. Dr. Purva also has the experience of serving as the president of the largest medical students organization in India, that is the Medical Students Association of India, amongst other leadership roles. She's been born and raised in India. She's had close witness to the disparities in healthcare from an early age and is committed to gender health equity and access to healthcare and surgical care in particular. Thank you for honoring our invitation, Dr. Purva.
Pleasure's mine. So glad to be here.
Thank you. We have Dr. Katayun Madani. Dr. Katayun Madani is a Global Surgery Research Fellow at the Sadhana Trauma and Surgical Initiative and is concurrently completing her Master of Public Health at St. George's University. She was born and raised in Iran and moved to the United States, where she completed her undergraduate and Master of Science in Tissue Engineering at Arizona State University. Katayun attended medical schools at St. George's University and School of Medicine in Grenada, West Indies, where she co-founded and became the first chair of Incision Grenada. She co-led a large-scale advocacy effort with the Ministry of Health Grenada, Grenada General Hospital, to deliver medical devices and supplies to furnish an operating room and intensive care unit. She led Incision's research team from 2017 to 2020 and has served as the chair from 2020 to 2022. Dr. Madani is the former secretary to the advisory board of the Association of Academic Global Surgery, that's AAGS, and currently serves as the executive secretary for AAGS. It's always a pleasure to have you with us, Dr. Madani.
Thank you so much. I'm honored to be here.
We have Miss Makina Huck. Miss Makina Huck, BSc Hons ACGI, is a penultimate year medical student at King's College London, who intercalated in biomedical engineering at Imperial College London from 2020 to 2021. She was a class of 2019 campus director and Millennium Fellow, a program run jointly by the Millennium Campus Network and United Nations Academic Impact, in which she developed her interests in the area of global equity and ethics by implementing a social impact project that focused on soft skills development. From joining 2020 Incision educational team and serving as 2021 Vice President for Internal Affairs, Ms. Makina is now the 2022 Incision Chair, and she hopes to expand the organizational development of Incision to continue empowering students and trainees. And Ms. Makina is currently a member of the Secretariat of the WFNS Global Neurosurgery Committee, as well as the EANS Frontiers Neurosurgery Committee. Thank you for joining us, Ms. Makina.
Yeah, thank you for inviting me. It's an incredibly huge honor, and we have such a fantastic panel as well. Like, there's no greater honor, honestly.
Thank you so much. I'll just go straight to our discussion today, and I'm really excited to be hearing your responses to the various aspects of today's discussion. We are recording, and after this, the recording will be shared on our social media platforms as well. That's on YouTube and Instagram, which will be shared and viewed by more viewers on our platforms. Now, when it comes to surgery in general as a field and the medical field, so much has been done. There's been great strides that have been done in terms of ensuring that there's women's representation in the medical profession over the years. Now, though the number of women who are graduating from medical schools has impressively increased, and in fact, in quite a number of schools, we're having either 50 to 50% ratio, and sometimes even more women graduating from medical schools, women are still making up less than half of the residents in all surgical specialties. And women remain hugely underrepresented in surgical leadership positions. So looking into these statistics, and there's quite a number of papers that have published this as well. What are the barriers that are preventing women from entering into surgical specialties? And I will begin with you, Dr. Susa, and Dr. Chaserem, you can go and give your response thereafter.
Okay, wow, let's start hard. So thank you for the question, and on behalf of all of my co-panelists, thank you so much to Incision for having us with you today. It's such a privilege. So, there are many, I think, reasons why there have not and are not a lot of women in surgery, and it's really because there are so many layers of barriers that extend from cultural barriers to institutional barriers, structural barriers, and in the end, perhaps the hardest to overcome are personal barriers. So what are examples? You know, cultural barriers would be sexism, which unfortunately continues to be prevalent in many, maybe most parts of the world. I think in the surgical setting, there is implicit bias even today, which is why we need to work so hard to correct these biases. And, you know, it's not just against women, right? It's against many other marginalized groups. And when I think about women, I think about gender equity, because I think it isn't binary anymore. It's really a continuum. And it goes all the way from maternity bias to affinity bias to, you know, likability bias to confirmation bias. So many different biases. I think fundamentally, what do we need to do? So we need to break down these barriers, right? And I think there's some discrete things to do. One, we need more women in surgery, and we need to empower those women who are in surgery to serve as sponsors, as mentors, as role models. Secondly, we need to support women in surgery who in many ways have unique challenges from men. Sadly, even today, you know, the responsibility of fertility, family, childcare, elder care continue to rest on the shoulders of women. And if we as a surgical community do not support those things, then women are going to leave surgery. And sadly, the pandemic has had that impact, at least in the United States, where women have been more challenged and therefore are more likely to leave our profession. And then finally, as many of you know, we had Pay Equity Day just about 2 weeks ago in the United States. I know it's celebrated in different parts of the world. Today in the United States, women are still making just 90 cents on the dollar compared to a man. So if a woman surgeon is doing the same work as her male colleague, but only receives 90 cents to his dollar, it is really hard to be able to keep them as a colleague. So I don't want to be Debbie Downer this morning, and I hope we're going to move to the things we can do to actually rectify this situation. Thanks so much.
Thank you very much. It's quite some shoes to follow on after Prof. Sosa, who's covered it quite eloquently. I think in the capacity that I sit with the Kenya Association of Women Surgeons, and 780 doctors. And of those, 154 are female consultants, and with about 98 coming through the system. So to meet a female surgeon is 0.01% of the doctors that you're going to meet. And many of those graduated after the year 2013. So they're in the early phase of their surgical career. So some of the barriers that come in recruitment are, for a long time, first, we didn't have equity in recruitment to medical schools for factors around affinity to science and seeing medicine as a career for women. So that was the first barrier. Then when you come into medical school, the question is whether you get the same exposure to the opportunity of a female mentor or a mentor who is welcoming both genders into the surgical field. And if surgery had been traditionally very, not even male dominated, I'd say very type A, patriarchal kind. So even many men did not choose surgery. The field is changing because the range of mentors who are coming through are changing. So that's another thing that's made a difference. And if we look at that, if I was to break down the data for you, you'll find like a field like general surgery has 27 women, making about 11% of the female, of the consultants are female. But a field like pediatric surgery, which is certainly much younger within the country, 4 out of the 13, therefore 31% are women. So bringing in new ideas, being people who are more open to a gender diverse environment creates that enabled environment for women to come through. So that's around medical school. Then beyond medical school, we have few training programs, and certainly in our country, for many of those training programs, you have to travel. to very many different towns, and often you have to be self-funded. And this happens in tandem with a time when many people are starting their families. So you find that women may not choose to go into surgery because they feel that their attention needs to be somewhere else. So to rectify that, we need to have better funding models for surgical training, and certainly surgical training that allows for areas around parental leave and maternity leave, so that we can retain the staff. And then now when you look beyond that, as we're looking at the group of women who have now finished their training, there are skill sets that are outside the operating room. So one of the things that people for a long time think they don't have is the technical abilities. You know, can you do that like a man? Can you put in a screw? Can you do that? And so when a lot of times women go into training, they're very focused on proving the technical aspects. But a successful surgical career, the technical aspect is only a part of it. So the ability to lead, the ability to teach, the ability to leverage in different rooms and create your own opportunities are certainly spaces that female surgeons in Kenya and in the region, and I suspect in many other areas, also need to learn, so that you can have a pipeline of women at every level who are there because of their ability and because they have been able to prove of what they're capable for. And once they do that, you tend to find that we already have a pyramid effect. Every specialty may have fewer women at the top, but many more now coming through in training because now they have positive role models. They think it's possible. Spaces are opening up. Work environments are more gender diverse. And I could go on and on and on, but I don't want to turn this into a sermon, but I think there's a lot of positive news coming through.
Thank you. There's definitely a lot of positive news coming through. And I like the point that you said about women being, told that they have to do a lot more of the technical aspects, yet there's so many other areas in which they can prove themselves, especially when there's positive mentorship and all these positive aspects coming in. And so what can be done so that we address the existing gaps when it comes to representation of women in global surgery and in specifically global surgical leadership? And I'll address this question to Dr. Swarup, and then Dr. Madani, you can respond after Dr. Swarup.
Thank you so much. Again, thank you for the opportunity to join these wonderful women on stage. I think that, the points that Dr. Sosa and Dr. Chesterman bring up are very important to address. And I think that on the global stage, in addition to that, we have specifically, even more so those gender roles that are, that play a part at home, and also the respect that global surgery receives, in the departments of surgery. As an academic field, right? So I think that there is also that aspect of things that it does not get the the same level of respect that other academic fields get. So I think that you have the normal, not normal, I should say, but the things that we just spoke about, right? The other issues that are there for all of surgical, not having enough women in surgery, but then adding on to that is all of the biases that exist towards global surgery in and of themselves.
Thank you so much. And I'm going to just follow up to what Dr. Sosa, Dr. Swarup, and Dr. Chesterman have said. They have stated the data and the statistics very well. We all know the data. We've seen it. We've seen the statistics. It's not an unknown issue. I think it's a very important question that you're asking. It's what to do. Right now, I think in 2022, we should be talking about solutions, and that's where we are. And I think this is something that has to be done at every level, at a student level, all the way to the mentorship and mentor levels. First and foremost, I think representation matters. It's very important to see women surgeons. When Dr. Chesterman says, coming in contact with a woman surgeon, your odds are so low to see a woman surgeon even in your lifetime. I was born and raised in Iran. Many people may not know this, but I'm the third generation of my family to go into surgery, but all the previous generations were men. I always knew I wanted to be a physician. I never thought about surgery because I always thought surgery is so difficult, so busy, because I had seen the realities of it. But something that actually brought me into surgery was the first time I stepped into an OR. Who took me to an OR? A woman trauma surgeon who was a mother, who was director of trauma research, and seeing that she can have a life, that's when I dared to dream about surgery. Someone who had been living with surgeons all her life. So that representation matters. It's so important. Visibility is so important for other women. We can now dream of becoming the president of the United States because we have seen women run for that position. It is palpable. We can feel that it's within our reach. So I think at every level, it's important to speak up. At every level, it's important to have that visibility, to have mentorship. Dr. Swarup has taught all of us over the years in Incision that you lift as you rise. So we can have peer mentorship. And that's something that has been at the core of Incision. And I think all of us who have been part of Incision are proud to say, for the short lifetime of Incision, which is barely 6 years old, we have always had women leaders in equal numbers or more than their male counterparts or men counterparts. We have always counted by hands, even for every focus group, every event, every activity that we do, every panel we set up, to make sure that there is representation. We provide opportunities for leadership, and we have created this culture very successfully that women are not only considered for opportunities, but they get the opportunities first, because our women and men, our co-conspirators, are very aware that these statistics are very real and they need to support and lift and empower their women colleagues. So I think it's time for all of us to take ownership of that and understand that at every level we can do something.
Yeah, thank you so much for mentioning that. Indeed, representation matters. And that is why I feel like even for some of us at Incision, we can be here because we have seen other women do it, and the same for other mentors who've been ahead of us. And I know at Incision being, I'll give you a chance, Dr. Swarup. Yeah, you're actually one of the mentors for so many of us. So thank you so much for helping us to just have someone to look up to.
Thank you so much. I'm sorry, I'm like coughing and sneezing, so my answers are a little bit like jaggedy. But I think that, one of the things that's really important in coming up with solutions is, like you guys are talking about, visibility, is meetings like these, right? Where we come together and we continuously talk about the fact that we need to have more membership in the tribe, right? And we need to have people being mentors. We need to have women being there for one another. And, the biggest thing is to, when you see another woman and you see someone who's struggling, if you see somebody who's like, hey, I'm thinking about going into surgery, or hey, I'm going into surgery, or like, I'm not sure what I should be doing. Hey, just have a conversation with them, right? Because each person that you sit there and talk to, you can affect their lives and you can make a difference in their life. And, that's, you start off with small changes, and those small changes become bigger and bigger changes, because every life that you impact then impacts other lives as well. And so it's kind of a beautiful thing to look at when you see that way. And I think that, as academic global surgery starts to gain respect, and there's an influx of individuals who come into that as well, there will be more women who join that, again, as that tribe increases. And all of these wonderful women who are on this panel are a part of that,
Yeah, that's true. So all of us are a part of this wonderful community, and I'm really appreciating to see Dr. Susa, appreciating the audience, and appreciating the time to come and join us, because this is a wonderful sisterhood community. I'd like to encourage our audience today, if you have any questions, you can put them on the there's a Q&A box or a chat box right there where you can put in your questions. And when you're talking about solutions and representation, we at Incision actually do try our best to have equal representation of women in leadership position, which plays a very big impact when it translates to taking up other leadership roles when it comes to the professional bodies in global surgery. And so I'll invite you, Ms. Huck, to explain further as to how Incision is actually playing a big role in this, even as you answer how we can support young people to continue taking up leadership position in global surgery at large.
Certainly. Thank you so much for the question, Gloria. So Incision from the beginning has always played a very active role in female empowerment and ensuring equal representation. I think it's probably best to start with my personal story from when I joined the organization in 2020, when we actually had two female chairs. We had Dr. Madani, who's with us today, and Dr. Shiama. And I think that is nothing that sends a stronger message to you when you're just joining the international team for the first time to see such a big symbol of female power, essentially. As I got further involved in Incision and I joined the executive board the first time last year, I learned that our processes are not, it's not essentially accidental to see female representation. It is something Incision makes an active effort. We advocate for it and we ensure it systematically in our processes. When we're making selections for people joining the international team for the executive board, when we select our panels, when we're thinking about the extra opportunities that are given to empower our IT members and our EB members, one of the key factors we look at is gender representation. And I think that is a very powerful symbol because sometimes it is very easy to lose sight that if you've got so many other factors, so many different events to keep in mind. So when you put that at the forefront of one of your essentially like one of the key factors of what you're going to consider in an organization, putting that at the forefront essentially is helping to ensure that that is something that we maintain is important and we keep working towards that. No organization is perfect. There are still things that we can do to make that better, but we're getting to the point where we're at least being able to identify what we could do that to improve that as we move through the organization and as it continues to grow. I was looking at some stats about our international team in the run-up to this webinar. Currently in our executive board, I'm one of the chairs. I have a fantastic co-chair, Shahnua, so we're balanced in that regard. We have 4 vice presidents on our executive board, 2 of them are women, and of the 6 directors we have joining us in the executive board, 4 of them are women. So at the highest level of leadership in our organization, we actually do have more women than men currently represented. In the IT, of the 98 members we have, I believe it's something close to 66 are female, and that is not a new trend. That has been a consistent pattern we have seen throughout the different years of the international teams that we have present. If we had to highlight key leadership roles that are present within sub-teams, we have seen consistently, we are already starting to see in this term already, but certainly in the 2021 and the 2020 term, which is when I initially joined Incision, a lot of the IT members who are in that position where they are taking on projects, coordinating their teams the first time are also women. And it's an incredible point to drive to show to the global surgery community what we can do in this regard, as well as the message it sends to other people who are looking at surgery or global surgery in general and seeing that it is an active and welcoming space for future female surgeons.
Yeah, indeed, it sends an active and a loud message. And I'll also invite you, Dr. Purva, to give your comments as well for that same question on how we can support young people to take up key positions in leadership and surgery. Thereafter, if Dr. Madani, you have more sentiments to give on the same, I'll invite that as well.
Thank you so much for the question, Gloria. And I think it's a very important question and it's pretty close to home for me. Considering that I am at a point in life right now where I'm supposed to decide which clinical branch I'm going to be working in and which center or which hospital or which exact place I'd want to work in. And the conversations that I have with my women colleagues are significantly different than the conversations I'm having with my male colleagues and the conversations they're having within themselves. Like, for instance, I don't hear my male colleagues talk about instances of suppression or harassment at these centers we're looking at, or how many other men than themselves are already in these institutions. And we know that these barriers exist. We all know the figures. We have seen different instances of this happen to us or even very close to us. And we've all spoken about mentorship and how important it is. And I truly just want to echo that, but add on, it's even despite having good mentors, sometimes a lot of us don't have enough resources to be able to really make it that far within our dream. I come from India and I don't come from a very affluent background. So the realities are very different for me than they are for many others. And putting that context when we are making a surgical or a global surgery workforce is very important. And as Dr. Sosa also mentioned in the comments, just minutes before this question was asked, sponsorship does have a very major role to play in where we go and what direction our surgical field and global surgery in general is headed to. For instance, a lot of my training and a lot of these workshops and mentorship programs that I've been a part of have been sponsored or have been funded by various organizations. And without them, I don't think I would be as far as I am right now. There's a long way to go, but even this journey would have been impossible. So finding these systems and making sure these systems are accessible despite the different inequities and differences that exist between contexts, between resources is really important in making sure that young people don't repeat this same pattern that's been repeating for so many years.
Yeah, I couldn't agree more, Dr. Purva. And I see Dr. Sosa, you've raised your hand.
Yeah, I just thank you so much for those words. You know, I think that one thing for attendees to take away is the power of self-nomination. First of all, like, put your hand up, take that risk. Often you are the only person who will volunteer, and all of a sudden there are opportunities. My second message is for those in the audience who might be mentors, sponsors, and role models. We need to nominate, sponsor women for opportunities. You know, there are plenty of data that show there's a leadership position. There are 10 criteria that you need to meet for that position. Men will look at it, they have 5 of the 10 criteria, and they're like, I am perfect for this job. I will learn the rest on the job. A woman will have 9 of the 10 criteria, look at it and go, I'm missing that one. Maybe next year I will self-nominate. And that's where the sponsor can intervene and take that risk to support the woman. So just a couple of things that came to mind as our last speaker spoke. Thank you so much.
Thank you. That's a call to all of us to be confident and to sponsor and support other women. I had asked you, Dr. Madani, to give, I'll give you 1 minute to give your comments on that.
I think, again, going back to the issue of sponsorship, I think that's very important. I'm really thankful Dr. Sosa brought that up. I think it's important for us to also think about in ways that we can echo each other's voices and we can raise each other's voices. When you are in meetings with women, oftentimes you see that a woman may present a idea and the idea may get lost in the voices in the meeting. It happens a lot of time. And then you see a man pick up that idea and speak it out, and that idea becomes his all of a sudden, and everybody agrees with that. So it's very frustrating, you know, when you're new, when you're young in early career, and this might be very frustrating and disheartening. So something that we can actually actively do for one another is in meetings where you see, or in the projects when you see a woman come up with a very good idea, echo that idea and say, you know, so-and-so's idea is good. We should think about that, raise those ideas, uplift each other as you go. And one more thing, I think for Incision and for our sister organizations in global surgery that exist, like the Gender Equity in Global Surgery Group, something that we need to really look into is that, you know, the gender equity issue as a whole. And I think we need to become more cognizant of that. And while there are cultural barriers, political barriers, various locations in the world, legal barriers even in some, we need to look for ways in which that we can educate ourselves, we can have representation more, and we can be more gender equitable across the board. And go just beyond just women, because we're not the only underrepresented group in surgery.
Yeah, that's true. Thank you so much for that. And when I look across this whole panel, I see that almost actually all of us as are associated in one way or another, or have done research in different capacity. And I'd like us to talk a little bit about that, because when you look at several studies, and just to highlight one study that was done by Silva et al. In 2019, where they demonstrated that gender bias in academic medicine, especially with regards to publishing in medical journals, and evidence has been showing that women face more barriers to the publication, resulting in unjustified underrepresentation of women authors, and not just the authors, but also reviewers as well as editors. And the first question I'll direct it to you, Dr. Sosa, because you have been, you are the editor-in-chief at World Journal of Surgery, which is no mean feat with all your experience you've had at editorial work as well. How do you see the current landscape and the barriers that women are facing in publishing and in playing an active role in editorial boards of surgical journals?
Yeah, so thank you for that question. You know, I think you know, as many of you will recall, it went viral, #MedBikini, which really, I mean, I don't want to pick on vascular surgery because it was by no means a problem isolated in vascular surgery, but it was really just a case study or example of a more pervasive problem that is fundamentally a problem in the underpinnings of peer review. I think how to repair the issues that were raised. One is we need to mentor, sponsor women to pursue surgical science in all of its forms, to become authors, right? And to do science. I think that's the first thing. But second thing, once they do that science, we need to make sure that there is a lens cast that emphasizes diversity, equity, and inclusion. So it always starts, I think, with leadership, okay? And what we need to do is to ensure that there are women in leadership positions in the editorial process. So that is women editors-in-chief. And we are nearly extinct, not quite, but there is a scarcity of us. Having said that, it is changing. I would give credit to Melina Kibbe at JAMA Surgery. I was her deputy editor. She supported me, she mentored me. She's a colleague, but she did those things, and I was then able to become an editor-in-chief as well. Secondly, we need to populate editorial boards, peer review with women, okay? And that is evolving. It's something we've been working on at World Journal of Surgery. When I became editor-in-chief, there were 2 associate editors. Now we are 50-50 among associate editors. So that's something we need to do. And it's an active and intentional process. I would say the last thing that is important, and something we just announced this week, is we just announced an ombuds editor for diversity, equity, and inclusion at World Journal of Surgery. And so this is the idea of having someone in leadership whose job it is to review accepted manuscripts, thinking about diversity, equity, inclusion. You would be shocked at how many manuscripts only look at male subjects. Like they look only at male patients or male animals, and they make conclusions that are broad sweeping, entirely inappropriate. Social determinants of health need to be called out as alternative explanations to biology for observed differences in outcomes, say, between the sexes. And I can give more and more examples. So those are some things I think we need to do. I think things are changing, but we need to press for that change.
Yeah, Dr. Chesaram, I see your hand is raised.
I think I just wanted to echo a lot of things that Dr. Sosa had said, but in this particular field also about what I'd term self-sponsorship. Many journals are looking, for example, for peer reviewers to join in the process, or looking for editors, etc. And it goes back to what you said before, which is if women are not willing to put themselves into the mix and learn on the job, then when the next position comes up, there is a smaller field or pot to choose from with experience. The same is true for telling our stories. So perspectives that include women in the publications, looking at the even the experiences about how we engage with health and health professionals, those do make a difference in how people are perceived. I remember in part of my training, it wasn't unusual for the guy to volunteer to do the poster presentation or to do the oral presentation at the conference. And what you forget is that over time, he gets experience. He might be rusty the first 1 or 2 times, but by the time he's in his 4th, 5th year of training, he's an expert. So if you wait until you're perfect, you never get a chance to go forward. And I speak about that from my personal experience, where I thought I needed to be at a particular level to have a voice. So yes, we need to really put ourselves forward and try.
Thank you. I'll address the next question to Dr. Swarup. How can we empower more women to take up the editorial positions in journals?
So I think Dr. Sosa answered that beautifully. A lot of that is sponsorship, mentorship, and really encouraging women that they can do this, right? I think that is a very important part of having women join editorial positions, encouraging women as young attending, as young consultants, to start the process of learning how to become a part of editorial boards. So empowering them early on and encouraging them to join leadership positions earlier on. So I think those things are probably focused early, things to be able to do. And that mentorship and sponsorship piece is just critical.
Yeah, and while we still talk about publishing and also being editors in journals, we know that there's a bigger gap now when it comes to low and middle income countries. And so I'll direct this question to Dr. Purva. What can be done to bridge the gaps that exist in publication from women authors in particular, especially from low and middle income countries?
Thank you for the question, Gloria. And speakers before me have covered a lot of where we are and why we are here. But in my response to your question, I think I'd just quickly like to mention a study that I recently was a part of conducting. A group of us got together to do a systemic analysis of author demographics in global surgery. And to no surprise, we, in a way, reflect the situation of women in leadership and women in surgical branches, even in the way we publish papers around global surgery and surgical specialties. If you leave out OBGYN, which had similar male and female authors, and if you specifically focus on branches other than obstetrics and gynecology, almost 65 to 70% papers were published by male authors only, no female authors whatsoever. And a lot of these authors also come from high-income countries. I think across board within publishing, we've started to recognize and accept that there are discrepancies within how LMIC authors and HIC authors have access to these opportunities. But I have rarely ever come across any journal that also tries to focus this attention to other groups within these disadvantaged authors from LMICs. For example, are we talking about women from LMICs in authorship? Are we talking about the LGBTQ community? Are we talking about other intersections that exist within the society? And one thing that, there's a lot of systemic change that is required. There's a lot of effort that Dr. Sosa mentioned, leadership in editorial boards. Unless we have women in these leadership positions, you cannot expect change to just come out of nowhere. We need it from the top. We also need to start working on what we can do individually. for example, everybody on this panel has had some experience with the research. And I'm sure we all know somebody who has absolutely no idea where to begin with in the field of research. How can we support that one person, even just light one candle on the way? So it's important to recognize that our role exists not only in systemic change, in producing that sort of change, but also driving change from where we are in our respective capacities. And how can we push authors? How can we push editors to incorporate more underrepresented voices? It could be something as simple as emailing an editor-in-chief of a journal that we're looking at to ask them what are they doing to promote women authors. Just to instigate that thought. Of course, it's impossible to make that change yourself if you're not in that leadership position. But how can you hold leaders accountable to bring that sort of change? There are APC waivers for LMIC authors. Are there APC waivers for other marginalized groups? Are there efforts being made to recognize that? And for everybody who's listening today on this webinar or watching this recording, I would urge you to go out and study the demographics within surgical specialties, within global surgery. We need more data to support these arguments. All of us have lived experiences. We need data to back this up, to speak with our experiences and put faces to this, put numbers to these faces and words that we're trying to bring out. So yes, that's what I think would help. Thank you.
Yeah, very well said, Dr. Purva. And Dr. Chasaram, it's good you raised your hand because I wanted to ask you to go next to give the comments on the same question.
I think one of the things that I wonder is whether it's about time to change the model of the current publishing, because most of the journals are in high-income countries, and there are multiple factors were very well demonstrated about the challenges if you're in the LMIC, right from how you do your study design, to funding, to some places have immature ethical boards. So it doesn't mean what you're doing is unethical. It's just that the process of authorizing your research may not be similar to somebody who lives in a high-income country. Yeah. So let me just say, I'm not supporting unethical research. I'm just saying the policy or the paperwork process may be different. So I think maybe it's a time to disrupt some of these models. So for example, if you look at the idea of Google Scholar, anybody can be ranked in Google Scholar. So you don't necessarily have to be in a PubMed index journal. But when it comes to, because most of the journals in low and middle income countries are not referenced in high income countries. If I write, for example, and I challenge anyone to read any papers around low income countries, written in high-income journals, the likelihood is they reference other high-income country authors who have done some research on low-income countries. In other words, they amplify
I think, Dr. Chasaram, we're not hearing you very well. I don't know whether it's just on my end.
Silence select the subject. It just dropped for a moment. What I was trying to say is, if somebody's telling a story, for example, if I say a story about your house, you would hope that somebody who lives there is the one who's a key storyteller. Yeah, if I'm getting the story always from your neighbor who lives down the road, then there is a problem. So in telling the stories of women, in telling the stories of women in low-income countries, in their interaction with healthcare or their experiences with healthcare, we need to have, and I'm looking at Dr. Sosa here, opportunities that promote those stories to come from the very people who live in that house. Yeah, and if we made that a marker of good authorship, then I think many more women from low-income countries will be included.
I think we lost you again, Dr. Chasaram.
And you don't get the same. Sorry, I'm back in. I hope it won't break again. But I think it just means that I think you got my point, which is, if you're going to tell a story about me, can I be included? Let me not be a subject.
You're muted, Dr. Jasaram.
No, I'd finished what I was going to say. I was trying not to talk too much.
Great, great. I'll give this chance to Dr. Susa to respond.
Oh, I just wanted to thank Dr. Chesterton for those comments. I think it's super important, this observation she is making around potentially implicit bias against authors and scientists from lower and middle income countries. And, one of the things we do at World Journal, and I think this is something important when you're looking for a destination journal, if somebody is writing about a lower or middle income country, we, for example, require that at least one author be from that lower and middle income country. And the second is we need to elevate authors, reviewers, and editors from lower and middle income countries to positions of leadership in the peer review process. And I'm embarrassed that it took us so long, but I think now World Journal of Surgery is the first journal to have an editorial leader from a lower middle income country. We just announced last week, Dr. Adam Gieru from Ghana is our new associate editor for health equity and global surgery. Not enough, so much more work to do, but these are the kinds of things we need to work for. And I would say we need to work together as marginalized groups. So it's underrepresented in medicine, it is lower middle income countries, it is women, it is so many of us working together rather than in competition. Thanks.
Yeah, very well said. Working all of us together to ensure that the underrepresented groups are part of the discussion and are actually on the table. Dr. Madani.
I just wanted to say that this is incredible to see, and we're very thankful, Dr. Susa, to see World Journal of Surgery taking this step. It's important to have these steps taken. As you said, it's the first. And I want to bring up an issue in continuum with what Dr. Chesaram and Purva said, Dr. Patel said. We need to also, as readers, as reviewers, as the audience of the scientific literature, ask the question, as researchers also as PIs, ask the question, who are we not seeing in the authorship list? When you see a paper published, and I've seen this often, about an LMIC country with a project that is very advanced, wonderfully done, and you see a list of authors that are 9 from a high income country and 1 from the LMIC, ask the question, who am I not seeing? We have not gotten our eyes used to that question. We are missing out on students, trainees, potentially even faculty who are working on these projects and not receiving authorship credits that they're supposed to because of agreements that they have made that they thought it will get the projects move forward. We have seen this happen time and time again in Incision and across the globe. And I think it's important now to pay attention to it and be willing to look for those sort of missing scientific presences that are not listed as authors, and try to make sure that we also propagate fair authorship and appropriate authorship guidelines. The guidelines are written, but that doesn't mean that everybody is aware of those guidelines. Doesn't mean that, especially in areas where research mentorship is scarce, that everyone who's interested in research, interested in being involved, necessarily knows their rights as a researcher and author. So I think that's something that we need to start paying attention to as well.
Thank you. And so when it comes to all these changes that we're talking about, sometimes culture and justice systems, it gets really rigid. But what do you think we should do for one another as women in order to ensure that we empower one another to take up space and make a difference in global surgery? Start with you, Ms. Huck.
Thank you for the question. That's quite an important question as well. What can we do? I think something that I've noticed is mentorship is a key aspect to ensuring that we can create a safe space where women can feasibly grow and feel comfortable to grow in as well. And with that, I think we need to be able to identify and understand the perspective that a lot of aspiring female surgeons or attendings are in the position of, which many of our fantastic speakers have touched upon throughout this panel. One of which is we hold ourselves to many higher standards because we feel like innately we don't belong, or we have to prove that we've earned the position we're in. And with that, when you're so harsh with yourself, you're inadvertently holding yourself back. It's not just something I've seen that happens at an individual level. It's something that I've noticed that most people look at, let's say, the only female surgeon in the operating room and somehow expect her to, despite the fact that she's female, to be performing better than her male colleagues, to be more on top of things, to be friendlier, to be seen as honestly like a semi-impossible mixture of embodying the most powerful, I say this very loosely, masculine characteristics, as well as their best received feminine characteristics, push them together. And that is what people see as the ideal female surgeon, and it's something that you can see in global surgery. So I think the change in culture needs to be breaking that down initially and genuinely seeing people from an equal perspective, not holding our female counterparts to higher standards, but hold them to the same standards as our male counterparts and reward them and acknowledge their efforts equally. I think something else that we can do is, if we embody that at the leadership level, it will be noticed and it will be seen within our team members, and then they will pick that up. And then they will pass that on when we empower those people to take up leadership positions, or when they go to different organizations or different schools or different practices. And I think that is organically the best way that we can enact that change, by starting at the beginning, ensuring that it is passed over and ensuring that there is a longer term implementation. Thank you.
Thank you for that, Ms. Huck. Now, we've had such lovely responses from all of you ladies today, but unfortunately, time is not on our side. I'll ask one final question and I'll give you a minute each to respond as you give your parting shot as well. What do you think we're not talking about or paying attention to when it comes to conversations about women in global surgery? I'll start with Dr. Purva.
Thank you so much, Gloria. I'll try to wrap this up quick, but I think one thing that we are seriously not paying any attention to whatsoever is that how, as a community, we have a role of empowering each other, but we also have some role in bringing people sitting across the table. How can we involve more men in the conversation? What is the problem? And how can we still keep this conversation going in difficult situations? For instance, I've been labeled the black sheep for talking about my discomfort with certain comments or certain conversations in surgical departments that I've worked with. And it gets difficult in situations like these. So I want to ask everybody who's in the audience to think of how they envision their role in bringing about this change and facilitating this conversation. It's easier to be done when things are conducive, but how do you support somebody who's trying to speak up in environments like these, where there is a lot of aggression and there are repercussions for bringing conversations to light? And I'd also like to bring forth the role that we have by just saying something. Silence is being complacent, and just saying nothing or letting somebody suffer because you can have repercussions professionally just brings down this whole progress we're trying to get across. So one valuable lesson that I've learned is, even if it's uncomfortable, it needs to be said. No matter what sort of consequences it has, the consequence, it could be a short-term consequence, but keeping shut, staying calm, and just staying silent, not saying a word, has larger consequences to the women that are standing behind you to be in the position you're in. So I think I'll just wrap with that and let the other speakers take it forward. Thank you.
Thank you, Dr. Purva. Ms. Huck, you can go next.
Thank you. I think something that we don't really talk about within global surgery or in surgery in general is how isolating it can be when you're a woman who's in a leadership position, especially when we factor in the degree of intersectionality. And I suppose something that I felt when I first joined the executive board was, there's not that many women who are wearing a hijab that I can see around me. Or when I'm on placement and I'm going into surgical theatres, I don't really see anyone else who looks like me. To the extent where we had to make do with the surgical caps because they couldn't quite cover my hijab. It's little things like that that can sometimes lead you to feel quite isolated when you're trying to go into something that you feel passionate about. And with that, it's something that I think we do address it by talking about how we need more women, how we need to empower women, how we need to mentor women as well. But I think at a personal level, we don't really speak about or open up about how how stressful it can be, or how much pressure it places on you, or how much responsibility you feel when you're representing a certain group that you're part of that you don't really see in the spaces you're in. And I think there needs to be more open discussion about that, to say that it's okay, but also to address the fact that a lot of that pressure usually comes from yourself. It can come from other people as well, but the most important things are how you speak to yourself about that and how you make yourself feel in those spaces as well. So it's a mixture between self-empowerment, but also creating welcoming spaces.
Thank you so much, Dr. Madani.
So I think what we don't talk about right now, in addition to what has been said, of course, is inclusion versus, being there, just the numbers. It's important to have women representation and women being in spaces and surgical spaces. But I think something that we don't talk about is, are they allowed, when women are in these spaces, are they allowed to be themselves? Are they allowed to be a woman and bring in everything that is involved in that identity? Are they allowed to bring in whatever cultural identity they have with them? I think it's interesting to see when we are even allowed into these spaces, we conform. How do we tone down our femininity or whatever makes us women to fit in these spaces? And the problem with that is a lot of those aspects of what makes us women are strengths. Those are the things that will make us diligent, that makes us perhaps in certain areas more detail oriented, etc. And it's a shame that we tone down everything. It's not just about the appearance. It's cultural perspectives that we bring in, even and especially about our LMIC colleagues. When they are in these spaces, do they really feel empowered to be themselves, to bring in everything that is part of them and their identity? I think it's more important to now start talking about, inclusion, and not just, bringing in someone into the space and saying, oh, we have the numbers to say, the stats to say that women are represented. Are they really represented? Are they allowed to be themselves and bring in all the gifts that they have to our spaces? Because then that's where we can actually really tap into the assets that these individuals are, to their resources of their talents.
Yeah, that's very beautiful, Dr. Madani. And on the comments, I'm just following through, and Dr. Susa is saying that courage in the face of fear is important. And another person in the audience today says, thanks, Dr. Makina, your last comment hit home. I'll have Dr. Chesaram.
Thank you. I think the ladies have said loads of very interesting points. I think the thing that it's not spoken a lot about is how the historical structures that we have can also create imbalance in the representation of women through various areas of the world. Recently, I was called into a committee to talk about decolonizing elements within neurosurgical global health. And I remember the first thing I thought is, I'm not sure I want to do this. And that's because it's the elephant in the room, literally, about how we experience privilege or bias in different ways based on nothing else than the geographical area we're born or the concentration of melanin, and how that has an effect not only in our practice as clinicians, in our ability to access research, but also in how we experience things as patients. And as long as we sustain that inequity, we will continue to have poorer outcomes. So when we talk about accessible, affordable health, then it's supposed to be accessible, affordable to the person. And the intersectionality of very many different women through their personal experiences mean that until we can talk about these conversations frankly, then we will not be able to achieve our goal.
Yeah, I think that should be in a poster somewhere, a statement. As long as we continue to sustain inequity, we'll continue to have, what did you say? We'll continue to have inequalities. We'll continue to have inequalities. Yeah, got that right. And finally, we'll have Dr. Sosa.
I am going to do something. I'm not going to give you my idea. I'm going to amplify what I have heard. And I would encourage all of us to amplify each other's voices. Sometimes the most important role you play as a woman is just to support the perspective and the voice of another woman. And you can do that strategically. Before you go into a meeting, what are you going to say? This is what I'm going to say. Then you say something else, and hey, let's call her and have her say it a third time. So what I've heard is incredibly important. I've heard we have to be courageous even when we're afraid, and I am frequently afraid, but you've got to work through it. Secondly, I really like this idea of intersectionality, and I would say weaponize your intersectionality. It is not a curse, it is a superpower, because if you are intersectional, you understand the perspectives of so many more people and take those perspectives and their voices to give you that additional insight and courage. And then I would say, you know, breaking down barriers across countries and taking on big issues as well as small issues. And I guess I just then want to finish by again thanking Incision. I think in the United States, one of the biggest problems we have is we look too much inside our own borders. And what we need to do is look outside of the United States, internationally and globally. I think the pandemic has explained the importance of our doing that, and hopefully that'll be something we continue to do going forward. So thank you to Incision and the leadership of Incision.
Thank you so much. You've literally validated our webinar by saying that it is intersectionality and it is power. So I'd also like to thank our audience today for attending, because you have contributed in a big way to the power that, you know, we hold today as women and the narrative that we spread about equity and taking up space in global surgery. Just to echo a few comments I'm seeing here, Christine says decolonizing neurosurgery, it's necessary, and she feels as though it lags behind many other surgical specialties. We have so many others agreeing with the various responses that have come from you ladies today. So thank you so much. It has been a great discussion, and I hope that we've all learned something. I know that we have learned something, and so it is a bye-bye from us. I'd like to request all the speakers to remain behind. But before we go, could we just take a quick shot, a quick picture? So just look at the camera and smile, and I will take the photo at the count of 1, 2, 3. There we go. Thank you so much. And all of you have a good evening, a good afternoon, or a good morning, wherever you are. Bye.